I think affirmative consent is really important. And I think in this moment of misinformation and lies and disinformation, that it's really important that we use the tools that, really reach the public and the people that we serve. And I always say that Nazis, bots, and trolls can't be the only people that are using social media. And then we can't turn around and wonder why misinformation is rampant. So you have my consent to be able to share a couple of things I'm going to say. I hope to cover a good amount of ground. I have about 40 slides. I'm not committed to getting through all of this because I do want to save some time for questions, comments, and discussion. One of the things that I think is important, I don't just want to, answer questions, but I want to be in dialogue with y'all because I fundamentally believe that we are brilliant enough as a community. We are creative enough as a community to really mitigate harm in this current moment. And that we have to unleash the creativity of everybody to really think about how we need to be doing our work differently in a post-Roe situation. And before I start, I want to be very clear. There was a time when Roe was not the law of the land in the country, and there will be a time when we can actually get something better than Roe. So I'm going to hold this tension between, it's very frustrating that, 50 years of jurisprudence basically been thrown out the window, and that for the first time ever in our country's history, a government has taken away some rights of its citizens. But I will also say it gives us a prime opportunity to think differently about how we could do our work and what we should be thinking about as a nursing, social science, public health, community-based group of individuals really thinking about the work that we're going to do. So with that, I'm going to see, I should be able to share my screen. Let's try this. Okay, my screen is visible to people. Awesome, I see some head nods. These are some of the groups I work with. I work across the reproductive spectrum. So the Birthplace Lab are my collaborators in Vancouver, British Columbia. We published some papers about mistreatment in the inpatient setting with Dr. Saraswati Vidam. Many of you know Advancing New Standards in Reproductive Health. I just came back from Oakland yesterday. We celebrated our 20-year anniversary of having science-informed policy. The Actions Program is a program I run at the University of California, San Francisco, which is a pre- and a postdoctoral fellowship program that really is grounded in reproductive justice. And then the Cherish program, the Community Engagement Research Incubator Strategy Hub, Ms. Joanne Allen is on this call. She's one of our Community Advisory Council members. It's all the community engagement work we've been doing to really innovate as a response to COVID-19, but we do a whole lot of other work outside of that as well. So, really important that we lift up the people who support us in doing our work. I want to dedicate this talk to 2 Black nurses who inform my world, my life, my universe. And I feel it's very important that we shout out the people whose shoulders we stand on. If you don't know these Black nurses, you really should. On the left, in the dub gear with the, Space Noodle in the background, that's Frankie Manning. She is iconic here in the Pacific Northwest and has done a ton of work with the Mary Mahoney Black Nurses Association, and nationally has done a ton of work with the National Black Nurses Association. On the right-hand side, you see me with Dr. Betty Smith Williams, who was one of the founders of the Black Nurses Association. I had the opportunity to meet her in person prior to the pandemic in 2019 when I was inducted into the American Academy of Nursing. If you don't know her, she is the first Black professor of nursing in the state of California in 1956. And she is still living, and she is just so amazing and badass. So we have to know our nursing history. We have to know our social science history. We have to know the trailblazers and the vanguard individuals who really allow us to be who we are today. That history is a gift from the past that should activate us in this current moment to realize that we can fix this environment that we're in. We're smart enough and bold enough to be able to think about how to protect the people that we serve and to achieve reproductive justice in our lifetime. That said, I am lucky enough to have one of the founding mothers of reproductive justice working with me as a postdoctoral scholar. That would be Dr. Toni Bond. Many of these people are still alive and are still writing and are still doing very important work. So as we talk about reproductive justice, you're in Chicago. We have to remember that that's where reproductive justice was born, right? This collaboration between reproductive health and social justice, that was coined at the Illinois Pro-Choice Alliance at the Ms. Foundation for Women in 1994. It was very important that we know this history. You sit on ground that was fertile for people to come up with a theory, a praxis, an advocacy tool, an organizing tool. That happened where you currently sit. So again, let's channel this opportunity for us to think about how to make this all different. People have seen me talk about retrofit, reform, and reimagine, and I'm not going to go through the whole slide set that I usually could talk about. I'm going to introduce those terms to you because I'm going to use them in this talk. These are the Merriam-Webster dictionary definitions of what retrofit, reform, and reimagine are defined as in the dictionary. And you can think about a retrofit as our past. That's reproductive health. That is reproductive health services provision. You walk into a clinician's office, they do your blood pressure, they'll do a bimanual exam, you'll get your pap smear, maybe you'll get some blood work done. That's reproductive health. So that's sort of a retrofit. That's what we have, a past framing of thinking about the work. Reform is reproductive rights. It's the legal protections that allow us as citizens to operationalize our rights. One could think about that's the present. The difference between a retrofit and a reform is in a retrofit, the inherent structure is not going to change. It is core to whatever phenomenon you're looking. In a reform, we can actually change things. And we just saw a huge change in our reproductive rights because of the fall of Roe with the Dobbs decision in Mississippi. Reimagine is a future, is a whole different way of thinking about things. And that's what reproductive justice is, right? It is a different way of conceptualizing health services provision and reproductive rights because it's grounded in human rights, right? The human right that every person has the opportunity to determine how, when, and where to make family and under what conditions they will birth. That every person, human, has a human right to prevent pregnancies with all the supports that they need with the dignities that are necessary in order for them to be able to operationalize their reproductive life course. Every human has the human right to be able to parent the children they already have in safe environments, healthy communities without violence, from any fear of violence from any individual or violence from any government or state, right? That allows us to talk about allowing disabled people to be able to maintain and not have to give up their parental rights, similarly with incarcerated persons, similar with migrants and immigrant communities, right? It changes the whole narrative. And it also allows us to disassociate sex from reproduction. Then we can have conversations about affirmative consent, healthy sexuality, menopause, pleasure, infertility, surrogacy, and a whole variety of other things that are very important to the people that we serve. So it's a different conversation. It's a really different discussion. I'm going to show you some very uncomfortable slides because I think in order for us to have a very nuanced discussion about Black women, about abortion, about where we currently sit, we have to tell the truth. And part of telling the truth means that we have to understand the conversation that we're having. So I'm about to do a retrofit and a reformation for you all. Margaret Sanger was trained as a nurse. She was a person who was part of that whole Lillian Wall, Henry Street Howe, public health nursing, New York City situation. And we have to own that, right? That it is inconvenient that she ultimately decided that she wanted to side with eugenicists and racists. But the truth of the matter is she was looking to address maternal morbidity and mortality as she saw it and wanted to really be able to provide contraception, right? So we can have this nuanced discussion about the complicated history of people in our field, as well as, the incredible good work that they could do. It's a both and, which is a conversation that reproductive justice drives, because reproductive justice also states that nobody's expendable and you can't throw anybody away. We have to have redemptive narratives in order for us to be able to operationalize reproductive justice. So let's own the problematic nature of some of Margaret Sanger's later work, and let's own the innovative work that she actually did grounded in public health nursing. This is a Facebook picture that got sent to me. If you can't read it, it says, "I know how you feel. When I was a slave down there, the courts didn't think I was fully human either." And this is a Black angel, apparently, with a baby sitting on its lap, and the baby's t-shirt says "unborn." This was sent to me in the early days of Facebook. And people thought this was a good idea to think about the fate of fetuses, similar to the fate of enslaved Black Americans and Black adults who, that their fates were similar. This is the kind of messaging that is very effective, that gets people in their feelings, that is not about science or policy, that really creates this polarized or this perceived polarized, because I'm going to show you some data that suggests that the abortion debate is one that I have found to be very, very lazy in terms of it's very easy to polarize people. I'm anti-abortion, I'm pro-abortion, I'm pro-life, I'm anti. It's actually more complicated than that, and it always has been. But I want to put forward an argument that there has been a concerted effort to keep people in their feelings about abortion, whether it's their own personal feelings or the experiences that they've had with other people in the constellation of their lives, that's really, really in direct conflict at points with people's professional and their individual responsibilities to other folks. Many of you will have probably seen some of these, right? The Billboard campaign, this idea that you would speak directly to the public and get them in their feelings about abortion. This idea, I mean, can you, on the left, if you can't see that this was in San Francisco, and it says, my dad, I'm the CEO of the house. The baby has a tie on and the house is the uterus, right? Or the most, Black children are an endangered species, or to suggest during a Black maternal health crisis where Black people who want to birth and are pregnant are dying at 3 to 4 times more likely than white people from pregnancy-related complications, to say that the most dangerous place for an African-American is in the womb is offensive, right? To say that the pregnant person is exclusively responsible for the death of their children, that abortion is genocide, to me that is offensive, because that completely ignores the context and the environment in which pregnant people are attempting to bring new life into the world. This idea that every 21 minutes our next possible leader is aborted and putting Obama's face on a billboard, it's offensive. And I was really glad that Black Mamas Matter and Sister Song pushed back against these narratives. But this was purposive. This is to get the public, this is to create a need to be on a side. And I reject that, because we in nursing know it's way more complicated. It's way more nuanced than this. On the left is a picture of David Daleiden. He is the person who was arrested because he created doctored videos for Planned Parenthood for the Center for Medical Progress. And on the right-hand side is the decision from Whole Women's Health versus Hellerstedt, which finally made us deal with this issue of what is an undue burden and for whom, right? We already knew that abortion was segregated into basically poor people were the folks who are the majority of individuals who have abortions. There is no racial majority of abortion patients. About a quarter of people who get abortions are white, about a quarter of people who are Black, a quarter of people are Latinx, a quarter of people state that they have some other race or ethnicity. When you group all people of color together, they are a majority of people who have abortions, but you have to control for the fact that they are also overrepresented in people who live in poverty. Right. So this idea that there is a majority of people who have abortions in the United States, again, that was a nuanced, like purposive, oh, Black women are having more abortions than anybody. I'm like, well, yes, and because they are underrepresented in people who have like employer-sponsored health insurance and access to contraception. Oh, and they're also overrepresented in people who have low incomes and poverty who don't have access to these other things, right? So this argument, this association that, Black people were having abortions at disproportionate rates in the population, without adding that additional context, you're being lazy in associating poverty with reproductive health outcomes without stating that the explanatory variable there is structural racism and not anything having to do with Blackness, right? The association between poverty and Black people is explained by structural racism. So this idea that we've been lied to, we've been manipulated, right? It's this notion that people have tried to sell us a narrative that we can reject, which is abortion is it's a moral thing, it's horrible, it's this, that, you're pro-life or pro-choice, and there's nothing in the middle. That's actually not true, and I'm gonna show you some data. When Amy Levi and I published this systematic review of nurses and care of abortion, with people seeking abortions, we were really trying to understand what was nursing role in this. And how historically have we been able to be a part of that narrative? Going back to studies as early as the early 1900s, we knew that the grant midwives were the primary providers of healthcare. for enslaved persons and free persons on plantations. They were doing relatively good care for the time. And we knew that they were caring for people across the reproductive trajectory and reproductive spectrum. So we wanted to make sure that those data were integrated into our review. Or when we looked at the big study in California, where we saw that advanced practice clinicians, nurse practitioners, physician assistants, midwives could safely provide abortion care. When we went back and looked at the qualitative data around abortion care experiences, what we found was patients were grateful. They name nursing, they name public health, they name their counselors, they name their doulas, they name their midwives as people who really gave them fact-based information, who allowed them to have comfort measures, who really went out of their way to make sure that their accompaniment, right, was able to be with them in the way that was necessary, that we had headphones and music and chargers in the waiting room and all to demystify all of the security threats and the cameras and the bulletproof glass, and all the different pieces, right? They knew that it was us who really made that a humane experience for them, right? So this idea that it's this either or thing is ridiculous. Dr. Angel Aslan James, who's there in Chicago with you all, clinician provider, many of you know her. She finished her PhD at UCSF, and I was really proud to be able to do this paper with her. What does the recruitment and retention and expert strategies look like for nurses who are providers of abortion care? How do we make decisions about providing ethically challenging care like abortion care? It was so fascinating and interesting for me to look through those qualitative interviews and to use a grounded theory approach to realize that there is a distinction that nurses make between participating in care. This study came out of something that I personally knew and struggled with, along with a whole lot of other people, is that our own personal pregnancy decisions may not impact our decisions to provide care to other people. I have recently been telling my own pregnancy story because historically I never wanted to tell it because people told me that it would be stigmatizing to people who had abortions, because I've never had to make a pregnancy decision in my life, right? And folks were like, well, if you say that, then that means that somehow folks are going to imply that abortion is wrong. I said, no, because I didn't finish the sentence. I have no idea what I would do if I needed to make a pregnancy decision. And I'm very grateful that I've never had to make one, because I knew I never wanted to be a parent. Right? We need to have more room for stories like this, because as a clinical nurse, I have provided abortion care. Clearly, I do abortion-related research, but I have no idea what pregnancy decision I would have to make in my own personal life. And we need to have more opportunities to say things like that there is a distinction between personal thoughts and feelings and our beliefs and the level of work that we do. This is where conscientious objection and conscientious provision can coexist. And we know in nursing that we hold the tension of opposites, right? We know this. We know that two seemingly conflicting things can exist at the same time. And that is another core component to reproductive justice, right? It's a both and. When we did a survey to figure out, after we changed the law in California to allow for advanced practice clinicians to provide aspiration abortion care, we had to ask the question, was that radical or was that routine? What we figured out was it was routine. There were APCs who were doing all sorts of advanced procedures beyond abortion care. There were people who were doing uterine inseminations. There were people who were doing endometrial biopsy. There were people who were already doing something within that scope. So it wasn't this like radical thing, right? Now, at least not the way the clinicians perceived it. They didn't see it much different to any of the other, instrumenting of the uterus that they were doing otherwise, right? It was this meaning-making component to it that we needed to really address. But from a technical skill perspective, they didn't see it as radical at all. And then we knew from the global context already the banning, the back and forth of the, the Mexico agreement, every time we would have a new administration, we would see, USAID and other, federal and government agencies having to go back and forth with gag rules and different laws that we knew in the global context already what this post-Roe situation would look like, right? So we have tools to be able to learn from other countries, especially like, Ireland, Poland, countries in South America, Colombia, that have decriminalized abortion. We have lessons to learn around what it means to be able to do harm reduction in our own country. So it's not like we have to start from scratch. If I haven't convinced you yet, we published this paper doing a retrospective analysis of the procedural sedation practices of nurses to show that we could confidently and competently provide this care. We do the exact same thing for people who have gunshot wounds, the emergency department, waiting to go upstairs to surgery. We are able to provide procedural sedation for a whole variety of clinical services. So what makes abortion so different, right? If somebody has a gunshot they're brought to your hospital, you're not going to turn them away in the emergency department. You're not going to treat their pain while they're waiting to go upstairs to surgery. You don't look them in the eye and say, who shot you? Or why did you get shot? So when you think about all these different ways in which we've been manipulated by people to think about abortion from a feelings perspective and not a science or policy perspective, we have to really unpack that and try to understand, how do we get to serving the people who come to us for help, for support? This study was so eye-opening for me. We did a survey in the state of California, and then we did a national survey with the Association of Women's Health Obstetrics and Neonatal Nursing, and I'll show you results from both studies. But this is way more complicated than pro-life, pro-choice. Way more. Even when you stratify by race and ethnicity, even when you stratify by religion, right? I mean, it is way more complicated. There is a mushy middle that the bulk of us sit in. In some circumstances, we are very, very, supportive of abortion rights, and others we're not. It's very messy. And to try and get at that numerically and statistically was really challenging. But the truth of the matter is, there are more people in the middle than there are on the margins. And we have to think about, how do we activate those individuals? The other thing that was so fascinating about these data is, similar to the estimates in the population, 1 in 3 nurses who responded to our survey, even those who said they are anti-abortion, had an abortion in their lifetime and reported that in the demographics of our survey. This comes from 514 responses that we had in California. Survey responses that we have, where we looked at complete data, because we had 2,500 people respond to the survey. But when we looked at the complete data, all the questions were answered. We found that the middle was really where the bulk of participants sat in terms of understanding the role of abortion in our society. We then published the data from A1. And the A1 survey was a larger sample. It was closer to 2,000 individuals, respondents from all 50 states, nurses who were currently and actively licensed and working in the field. And what we found was, when you ask questions on an abortion attitude scale, the bulk of respondents, 88%, fell in the middle of our scale, right? This is not pro-life, not pro-choice, somewhere in the middle. And it was circumstantial and situationally determined. So at some point, we have to wrestle with what that means, right? If we can't get everybody on the same page about under what circumstances, where, when, and how abortion should be provided or determined in our society, I think nursing can push that conversation, especially given the fact that for far too long, we've studied the outcomes of pregnancy and not pregnancy in and of itself. Let me say this again. We have not studied pregnancy, right? Abortion is an outcome. Birth is an outcome. Miscarriage is an outcome of pregnancy, but the condition is actually pregnancy. So at some point, we have to clean up the science around, what are we really studying? And how do we think about pregnancy in the context of risk? So one of the other reasons why reproductive justice is so important is it forces us to decide who is the arbiter, the legitimate arbiter of the resolution of any given pregnancy, since all pregnancies end, right? If all pregnancies end, then who is the ultimate decider that gets to decide how that pregnancy ends? This frustrates me to no end, because we trust patients to diagnose themselves with pregnancy. Anybody can walk into a CVS, Walgreens, whatever. They can diagnose themselves with pregnancy. People can diagnose themselves with the wantedness or the intendedness or the right co-parent or the right time. We allow people to make those kinds of pregnancy decisions, but then we want to control when, where, and how those outcomes matter. And I want us to wrestle with that uncomfortable reality. I talk about rediversifying the workforce. I've already hinted at this from a retrofit perspective. We had a diverse workforce, right? And so it drives me up a tree when our physician colleagues or other people start talking about, oh, we have to diversify the workforce. I argue we already had one. It just got discredited because the grand midwives were taking care of everybody. And so there's across the reproductive spectrum. So this idea that we have to rediversify the workforce without talking about the implications of the Flexner report and how that closed so many historically Black colleges and university healthcare systems, right? Without talking about Shepherd Towner and the discrediting of the Black grand midwives. How are we going to talk about that without that historical context? Anyway, the reason I run a program that is specifically grounded in reproductive justice is it really came out of this notion that I went to all of my funders and I was like, I'm going to quit. I need help. I really dislike being an only, and we need more Black researchers, more Black scholars, more Black clinicians, more people who can get it. And I really branched it out to Black, Indigenous people of color, because we need more people studying the complicated, the nuance, the messiness of reproductive justice. And so my funders were like, yep, you're right. We're going to give you some money and we want you to build out that workforce. This was our founding actions team. And we did this at the University of California, San Francisco. For anybody who knows, I've said this on Twitter. I say this everywhere else. Until I left, I was the lone Black tenured associate professor at that level on the entire campus of 3,516 faculty. So to be able to, and Black people, only 3% of San Francisco's population. So to be able to convince funders that we could diversify pre and postdoctoral fellows, pre and postdoctoral scholars, and be able to populate these individuals at academic institutions was no small feat. But Dr. Alicia Schwartz, who's here, she's a tenure track faculty member right now at CSU East Bay, California State University in the East Bay. Laura Sanchez is running the Federally Qualified Health Center and the School-Based Health Center in Oakland. You can't tell me we can't diversify a workforce. Nurse Brittany Farrell is in Detroit, Michigan, doing incredible work, is now a PhD student nurse. Y'all might recognize her because she was one of the nurses that was in the forefront of when Eric Brown and Freddie Gray were murdered, and she was all over the national news. Olga Smith is leading racism in the NICU work at the University of California. Rachel Applebaum is in Boston doing incredible community engaged work with homeless populations and people of reproductive age. So you can't tell me we can't diversify our workforce. You can't, because we've been able to do this with our whole team. This is what our team looks like now. I was lucky enough to meet with some of them yesterday. Governor Newsom just signed a huge number of abortion bills, including freeing up $40 million for academic institutions who want to be able to train individuals to do abortion care, as well as individuals, including loan repayment for those individuals who want to be able to become reproductive justice informed providers, $40 million out of the general fund, right? And we are now gearing up to really start to think about how can we have reproductive justice informed curricula that will prepare that future workforce to be able to provide care to meet patients wherever they are, right? We wanted to build out a canon to really shift this narrative. There's nothing wrong with Black pregnant capable people. There is nothing wrong with abortion across a reproductive trajectory. People are now finding out the essential role that abortion plays in the provision of reproductive health care. I mean, how many stories have you seen about cancer patients having to delay their care, or people with autoimmune conditions can no longer get methotrexate because there are pharmacists who are worried that it's going to be an abortifacient? This has ripple effects throughout our entire field, and we need to put our foot down and say this is an essential health service that has multiple implications for many, many kinds of patients that we serve. One of the first things that I wanted to do was good luck with reducing maternal morbidity and mortality in the context of not having Dobbs, right? I mean, we need to think about how are we going to change our basic metrics that historically we've used to understand, maternal child health indicators in the United States. What does early entry to prenatal care mean? If you spent a month trying to get a wanted abortion, driving across state lines, you didn't get it, but you probably had an ultrasound. You probably talked to a counselor. You may or may not have had, informed consent with a clinical provider or a discussion with a clinical provider, but that won't get counted as early entry to prenatal care. And then people will turn around and blame you for late entry to prenatal care because you weren't able to get a wanted abortion because you spent a month, right? This is that's why I keep saying to people, we have to have some real discussions. Early indicators and other metrics that we've historically used as high quality prenatal care, those need to be reimagined because they don't make sense anymore in a post-op world. Otherwise, patients are going to continue to get blamed for their outcomes, right? COVID's not over. And part of the reason I went in the Kaiser Family Foundation videos to be able to talk about vaccines is because COVID is not over. I wrote this in March of 2020 when New York City was banning accompaniment. I already talked about accompaniment and how we've been crucial in allowing for that to happen in the abortion and reproductive justice space. Can you imagine how immoral and unethical it is that our healthcare system is so broken that we will shepherd new humans to this plane and expect birthing people to do that alone? If you're courageous enough to have a birth during a pandemic, you should have everybody you want there, right? I mean, so there is something wrong with our thinking if we are really starting to want to protect organizations and institutions more than the people who work in them, more than the people who are seeking care there. Prior to COVID-19, pregnancy and childbirth related issues were the number one reason why people had healthcare interactions, right? So this idea that we didn't use it as a prime opportunity to reimagine all of that, reproductive justice would have pushed us to do that. Some places did. We got the drive-through baby showers. We were able to do the, drive-through non-stress testing. And we finally got telehealth reimbursement, right? At rates that was also commensurate with in-person visits, but that took some of us have been working on that for 10 years. We can fix all of this. You just need the right levers to be able to do so. So part of my job is to activate the social science community, this nursing community. How are we going to infiltrate our existing structures and make them different? Right? This is a no-brainer. Right. I love Lauren Underwood. She's from, Chicago or Illinois. And, that we should have done this years ago. Right. And I think we should have postpartum Medicaid coverage. I actually think we should have pregnancy end Medicaid coverage, regardless of how pregnancies end. Because I think it's cruel for people who have stillbirths and miscarriages to not be able to have postpartum coverage. I think it's cruel. Right. I think it's cruel that people have abortions because of stigma. They go right back to work. And I think we should have, if your pregnancy ended, coverage, period. And to really think about that, to give people the time. And fundamental from nursing, we know that bonding and lactation, but even grief and engaging with the co-parent, people need time, right? And we should invest in that. That is a public good. And we need to start talking about it like that. Right? That in order for us to be able to, propagate our species, to think about the creativity of humanity, we need this for any time any pregnancy ends, right? I wrote this in Scientific American. I stand by it. We're going to expand this in a book chapter that Dr. Christy Littlejohn and Ricky Solinger, iconic Berkeley School of Law professor, they're editing a new volume. We're going to build out this argument. It doesn't have to be either or. And we can curate a space where this can be nuanced and troubled and complicated, because that's the kind of workforce that we need to build. That's what the people who we serve are looking to us to be able to do. That's where nursing can unleash its superpower in partnership with social scientists. So at some point, reproductive justice calls for direct action. Similar to the civil rights movement, there has to be action if you're going to talk about justice. So at some point, we have to be bold and in the Hyde and the Helms Amendment. It is unfair that your insurance dictates the kind of care you can get. People who've been pushing back against religiously affiliated healthcare have made this exact argument, right? It is unfair that if you work at a religiously affiliated institution and you don't share that religion, that somehow your choices are limited because your employer gets to decide what you have access to and what you don't have access to. This is like a slippery slope. This is dangerous, y'all. I mean, this is the Purvi Patel situation. She was Hindu. She went into a religiously affiliated organization. She died because they wouldn't give her a necessary abortion, even though her baby was dead. Like this has real world consequences. The minute that we make corporations and institutions have more rights and protections than citizens, we have a problem and we need to call that out. Your insurance shouldn't decide, just like your zip code shouldn't decide the kind of care that you get or your life expectancy, neither should your employer. So we have to start talking about these things. For people who don't know, this is Steph Toti. Steph Toti was the second youngest lawyer to ever argue in front of the Supreme Court and win with a reproductive health case. Sarah Weddington was the first one, and she argued rough. So Steph Toti argued Whole Women's versus Hellerstedt. And she has a project called the Lawyering Project, where early on during the Obama administration, she realized that there were some trigger laws that were on the books that would immediately go into effect if federal Roe ever fell. And so she got right to work in 2014 and was like, let's do a systematic review of the law. Let's figure out where the different touch points where we need expert witnesses and people to be able to protect at the state level abortion access. And I've been working with her. I know a lot of other nurses and researchers have been working with her to really shore up and codify state constitutions as a harm reduction tool to make sure that people get access to the care that they need, right? This isn't rocket science. It allows us to really think about, like, how can we be using existing law and new jurisprudence to be able to protect and lift up the people that we serve? This physician only thing, I hate physician only. I don't care what the clinical service is, but in abortion it's very, very cute. And now post Dobbs and post Roe, that was the ultimate equalizer around physician only. People used to argue, oh, well, we only want to train physicians because they can go anywhere and provide abortion care. Shoot, Dobbs made that go away. In fact, in some states, midwives have a greater scope of practice to be able to provide reproductive health care than physicians do. So can we now have a conversation about who can be clinical providers of full scope reproductive justice informed care, including abortion? Can we now have that discussion and developing that workforce? Because physician only is no longer an excuse not to expand people who can provide care and provide services. Why does all of this matter? Why do I care about this as a nurse? Why do I care about this as a public health person? Why do I care about this as a researcher? Why do I care about this around health equity? Because my field has been targeted by anti-abortion people peddling non-evidence-based, unscientific procedures that are very problematic. So medication abortion reversal or medication pill abortion reversal or abortion pill reversal, which is run by an organization called Heartbeat International, took over a crisis, they also run a ton of crisis pregnancy centers around the country. And in some places, crisis pregnancy centers or pregnancy help centers, which are not licensed clinical facilities, are getting more Title V and Title X dollars than actual public health departments. And they have been forcing this issue. In fact, they had the California Board of Registered Nursing mandate this class in abortion pill reversal until me and Answer and a whole lot of other folks got involved to make sure that that was overturned because it's not evidence-based. And in fact, if you start a medication abortion and don't complete it, we found that not taking the mifepristone can actually be harmful. That actually came out of a study that Mitch Creenan had to stop, a double-blinded randomized controlled trial, really trying to build the evidence to see if this worked. And we found that for people who took mifepristone but didn't take the misoprostol, that actually was harmful, and 3 people ended up having to go to the emergency room for heavy bleeding. So nursing was targeted early on for non-scientific, not evidence-based clinical practices in reproductive health. During the Trump administration, we actually had a government official state that an undocumented teen who received a wanted medication abortion should have to be forced to reverse her abortion. Government trying to force people to reverse an abortion. We all should be frustrated, upset, and activated by things like this. When you have government officials saying that you have to reverse a decision that you as a sentient being made, right? This is a problem. People asked me why I was on abortion-related billboards, and a lot of people told me I was going to ruin my career and I would never, get tenure, and I was not going to be a successful researcher because you was on abortion-related billboards. And I just sat there and went, because sometimes doing the right thing means doing things that your mentors, your colleagues don't necessarily can see in real time is the right thing to do, but that's something that you need to do. Attorney General Javier Becerra, at the time he was here in California as our AG, he is now the head of Department of Health and Human Services in the Biden and Harris administration. He was arguing a case in front of the Supreme Court called NIFLA versus Becerra, where many of these crisis pregnancy centers were suing under a First Amendment protection. They didn't want to have to put signs in their windows stating that they were not licensed clinical providers. They wanted to continue to lie to the public and coerce people into coming into their facilities in order to be able to receive goods like diapers, formula, car seats. And they would make patients sit through, indoctrinating, hours-long videos, pamphlets, to try and get them to be able to convert in order to be able to receive these social services. So as nurses, we need to call this out to be able to say one of the reasons why we need a robust social safety net that is, taxpayer funded and brought forward. We're never going to achieve health equity if we don't have that, because otherwise there's corporate interests and or religious interests that are mandating that individuals are indoctrinated into what they want them to believe in order to be able to receive those services. And as citizens in a free republic, we reject that, right? We need to be able to use that kind of language. We put these billboards up all over the Bay Area, in NorCal and SoCal. And it was really trying to get fact-based information out directly to the public. So in my last couple of slides, let me activate you all to be thinking about, because this is a collective effort. This is not the Monica show, right? I'm not going to figure this out by myself, because if I was, I would have already done that, right? We need many minds thinking on different levels of what is the retrofit, what's the reformation that's necessary, what's the reimagining that we need in order to be able to do this work and to really activate nursing, social science, public health in ways that will allow us to be able to mitigate harm, but then also create the kind of conditions and environments in which people can optimize their reproductive life. So first of all, let's not just focus on losses. Dobbs sucked, right? That's as professionally as I can say it here without using profanity, right? It's horrible. However, we've had some wins. Right? I don't even have Chicago in here, but y'all actually have some wins as a Haven state, as a state who is a demonstration project for the postpartum Medicaid expansion. Lauren Underwood has been working for y'all, right? But let's not act like we didn't have a big win in Kansas, right? Those community organizers that really, really would not allow them to change their constitution to take rights away from people. We had a huge win in Minnesota. I led the expert testimony in Minnesota, removing physician only, removing judicial bypass for young people, adolescents, and juveniles who want to seek abortion care, removing all of the sort of targeted regulation of abortion providers. There's trap laws, right? Huge win. Hawaii expanded advanced practice clinician provision of abortion, even before the Dobbs decision. Same in my home state of New Jersey, right? We've had some wins. There are ways for us to partner with people to be able to get racist bans removed, to achieve health equity, operationalize reproductive justice, but it's got to be a collective effort, right? There's a blueprint for sexual and reproductive health rights and justice. I spent most of last year trying to convince the Biden and Harris administration, this of course was before the insurrection, that we needed an Office of Sexual Reproductive Health and Well-Being, right? That we needed to be able to have an office at the cabinet level to be able to advise the administration on these issues. This blueprint that came out around reproductive justice was signed by 90 organizations during the Obama administration. We updated it for the Biden and Harris administration. It is freely downloadable that really maps where are the policies and procedures at HRSA, at NIH, at the National Science Foundation, at the Board of Education, at the Department of Defense. It has, so we have to level up our expectations, right? And if at some point, and I know we are like universities and nonprofits and this, vote in November. We need to have people who represent our interests, and our interests are more messy than the polarization that we've been led to believe truly exists. Because if you still believe in science and you still believe in data, the data show that many people than not are in the middle around reproductive health issues, and we need to operationalize and capitalize on that. So in summary, workforce development matters in the abortion care provision context. We have to link abortion care to reproductive justice and human rights. This is essential. I worry about us saying that pregnant, capable people have to take on the risk of pregnancy. We know pregnancy is 4 times more dangerous than abortion, right? People act like pregnancy is risk-free, and it is not, right? I worry that we have not done the hard work that we do every day in acute care settings, in VA settings, in an outpatient setting. Nurse, we can build nuance all day. We do it between families and communities, clinicians and community. We do this day and night, right? We translate our skill set to really be able to host some of these difficult conversations. We need to be doing this here. I want everybody to know that conscientious objection and conscientious provision can coexist in individuals and institutions. And we need to make space for that, because I think that's super important. And when the public has trusted messengers, we can effectively convey public health messaging. I think we have not done enough media training. I mean, you're there in Chicago. The Op-Ed Project is there. I have done many webinars with them. We need to have media competencies, strategic communication competencies for nursing students. My mentor, Diana Mason, and Barbara Glickstein just published a piece on this in Nursing Outlook in the current edition, talking about what are those competencies that we should have for media, for nurses. We can't sit around and keep bitching and complaining that our voices are not being heard in the media, i.e. the Woodhull study, right? Because in 1998, we found that our voices were being heard 4% of the time in the media, on TV, on the radio, and in print. And when Diana Mason, Barbara Glickstein, and Christy Westpalm repeated that study 20 years later, that had dropped to 2%. Right? If this is not an essential part of our job, of our role, then we can't be upset when people don't seek us out as the clinical, educational, policy, and research experts that we are. So I hope this is helpful. I am looking forward to comments, questions, discussion. I hope I didn't go over. Somebody, I hope, would have told me my time was up, but I am who I am. I'm gonna stop sharing my screen so that we can see each other. But I am really hoping that it's helpful. If you have questions, you can tweet me. You can use the chat. The people who are organizing this will tell you how to get questions. Also, I know there are folks in the room, but I'm curious about how can we have a dialogue about this? What questions you have? What discussion points? What do you want me to know? Where am I wrong? Where should I be thinking about other things? I would very, very much like to be able to have a dialogue about this. So thank you. Who am I looking at in terms of like a person who's going to help me? Oh, there's a lot. Wow. Okay. That's a lot. Okay. So can I take the DM questions that I have first? Who's directing me?
Okay. Can Monica see the questions?
Well, there's some I got directly asked to me. then there's some on Twitter. Okay, so I'm not going to reveal anybody's identity, but I guess there's other folks. If you want to like respond to everyone in the meeting as opposed to just me.
Okay.
Let me go ahead.
I think what we can do is I have a couple questions that have been put in the chat.
Yep.
Probably
Okay.
have a couple questions from the audience, and I think maybe you can pick one from the chat that you are particularly interested in.
Yeah.
So the first question, first, Manners, thank you for that really like provocative and inspiring. That wasn't a talk, that was something else I have to find the words for. Thank you.
Well, thank you. And I try to
I
engage
feel very much
audiences.
riled up right now. So yeah.
Well,
So
as teachers, it's our job to activate people, right?
yes, and you definitely have done that for me. So here's the first question.
Okay.
And it's something that you mentioned at different points, but can you just say a little more about the relationship between reproductive justice and harm reduction?
Yes.
You talk about harm reduction quite a bit in your comments.
Yeah. So for people who are unfamiliar with the concept, harm reduction is something that comes out of the substance use community, not exclusively, but it is a situation where instead of trying to cure or fix or have some endpoint that is static, harm reduction means that you will meet people where they are and try to assist in reducing harm, right? It literally means what it's named. And so it may not be, quitting cold turkey. It might be supervised injection, right? And making sure somebody doesn't overdose, right? So there's steps like within a harm reduction model that are more safe, and or less harmful. Similarly, we do this all the time in sexual and reproductive health, right? We know that we want people to use highly effective contraception in order to prevent pregnancy, but we also want people to use condoms and other barrier protection to prevent STIs. And sometimes you're going to get some people who use one or the other, right? But we want to be able to work with them to know what their risk assessment is for pregnancy and or for sexually transmitted infection and or both, and be able to give them some language and some skills and some tools to be able to negotiate that with the people that they're engaging in sexual activity with. So similar to reproductive justice and harm reduction, one way to think about that is the National Network of Abortion Funds, people who provide people with practical technical support in this, like needing to travel for abortion care, right? If you know that you're going to have childcare, if you know that you're going to be able to have gas money, if you know you're going to be able to have a hotel to stay in, that's like you not taking stuff into your own hands, right? And let me be very clear. Prior to the 2000, when RU486 mifepristone was developed, we knew that self-managed abortion was not as safe as it is now. We have new technologies right now. We have something we didn't have when Roe didn't exist, which is mifepristone and misoprostol. So we know that it is relatively safe for people to manage their own abortion outside of the context or the umbrella of medical supervision. So harm reduction can be making sure that somebody has good phone numbers and or accompanying meal delivery services if they're going to have a medication abortion at home. Like there are ways that we can think of what's a reproductive justice approach, not stigma, shame, judgment, and blame. But how can we get people what they need to be able to safely be able to end their pregnancy in the context of reproductive justice, right? In the same way we want people to have a safe, vaginal birth after cesarean, in the same way we want a safe home birth, right? These things are not mutually exclusive. So reducing harm means just that. It's giving people the social and clinical supports that they need, information, right? A lot of clinics wanted to stay away from self-managed abortion if somebody started abortion with pills at home because they thought they were going to be legally liable. Like we have to think about, and I've been talking to the Emergency Nurses Association around this. We cannot call the police on our patients when they admit to us, right, that they've had medication birth. That violates patient-provider, relationship and the standards of our code of ethics in the ANA. And yet we still see situations and circumstances like Lizette Hernandez in Texas, where, nurses called the police on her when she revealed that she had attempted to have a medication abortion at home, right? That we can educate our profession about, remind y'all that we have a code of ethics with interpretive statements under the American Nurses Association that demands that we hold the patient-provider relation sacrosanct, and that supersedes, any criminalization of pregnancy or pregnant people. So that's what I mean by reproductive justice and harm reduction, right? What are the actions that we take as clinicians, as researchers, as data, right? The new iPhone 14 is coming out and it has an ovulation tracker. I tell people don't use that until we get a good, strong privacy law in the United States, protecting Facebook from turning over your messenger data to the government so that you can be like, arrested for your medication purchase. Don't use these trackers until we can get a good privacy, My Body, My Choices Act that's languishing in Congress, right? Without digital privacy, that is a harm reduction strategy. So really trying to think about this notion of we as nurses, we meet patients at every juxtaposition, every intersection, whether it's, through the VA, whether it's through federally qualified health centers, school-based health centers, whether it's actual healthcare and hospital institutions, right? So we can be using our most trusted currency to actually be able to provide people with fact-based information and harm reduction tools so that they are not criminalized because of some pregnancy outcome.
Okay. Can we have one question from the audience? Any questions from the audience? Because I have a list here.
Well, I am committed to answering the questions. If you send them to me, I will answer them as best as I can, or try to get resources to people. Folks can also hit me up on social media. I didn't say this. I'm McLemore everywhere. McLemore MR. I will answer your questions there too. But I am committed to answer questions, and because I know this is like nobody curates a space for people to be able to talk about this stuff, and we have to be able to talk about this stuff. Right.
Yeah, and I have I have a few questions actually are coming from students, so we can actually deal with that during the student portion of the conversation. So
yeah.
Without further ado, let's give Dr. McLemore a round of applause.
Well, thank you for being here. I'm so grateful that, we get to have discussions like this, because one thing I forgot to say too is the communities that we serve, they have the answers. We don't have any answer that no pregnant person and their family, their parents, the co-parent, their own kids, they have the answer. We have no answer that they don't have.